For the roll. Welcome, everyone. Welcome. Good evening.
Hello.
My name is Don. I'm one of the therapists here. This is Dee.
I'm one of the other therapists here.
One of the six therapists. There's 6 therapists here now. Welcome again. So tonight we're going to be going over some information about the rotator cuff and specifically the rotator cuff and some other issues that may arise with the shoulder. Yeah, so first, before we roll through it, I want to kind of get a little bit of information from each of y'all. So we have a small group, and we kind of tag along with some of the ideas and some of the trouble y'all are facing. Okay, so ma'am, so with you. Sure. So what's your name?
Karen.
What is it?
Karen.
Okay.
K-A-R-I-N.
Okay, Miss Karen, how you doing?
Great, thank you.
What shoulder is bugging you? What shoulder is giving you?
My left shoulder, yeah.
All right. How long have you been dealing with that?
About 3 months, I fell on it.
3 months with a fall. Okay. Okay. Has it been has it been the same, or has it been getting worse, getting better?
You know, it comes in waves.
It comes in waves.
Yeah,
Okay.
it really does. I still have decent movement. I can't do this, I can't do this, and I
Okay.
can't lift anything. I have no strength in this.
No strength in the left arm. Okay. All right.
And I had an MRI and everything, and the doctor wants to do surgery.
Okay.
Yeah.
Okay.
But
Like ASAP or?
I try not to.
I got you. Well, thank you for sharing. Goodness. Yeah. Did he recommend PT or anything like that, or injection?
No, not yet,
Not yet. Okay.
In fact, I have to call him, but you know.
Okay. Okay. Well,
I
thank you
just
for
had the
sharing.
MRI done, yeah.
Okay. Okay. Sir, good.
My name's Kelvin.
Okay. And what's
Right shoulder, so exactly is what she had said, but
Okay.
the right shoulder, I do have a torn rotator cuff, I did get an MRI.
Okay.
I was going to physical therapy another place, and then I stopped going after I figured out that I had torn rotator cuff.
Okay.
Because the doctor mentioned that I will need surgery at some point, but I
Okay.
decided to do it. What was the other questions that you had there?
What kind of activities aggravate your pain?
Oh, pretty much anything, sleeping, it wakes me up every night, and sometimes just certain movements will pretty much put me in ease.
Okay. So sleeping, glad you brought that up. We're going to
Sleeping
go
is
over that.
wakes me up, and it just feels like it's
Sleep as
just,
well.
it's just a pain all the time.
Okay.
Just a numb pain. And it goes dead.
That arm is okay.
Yeah, we're going to kind of get into that as well.
I'm pretty good playing talk.
Yeah. I forgot to mention, is anyone in objection to us taking our mask off? No,
We're staying 6 feet
it's 6
apart.
feet.
I'm not.
I feel like we will
Yeah.
not mumble as much.
Right.
Yeah.
Right. Is that be okay?
Yeah.
Okay. Yeah, if anyone has any issues with it, please let us know.
So I never guessed you had a beard.
Hi,
My name is Joyce,
Joyce?
and this is my right shoulder,
Right shoulder.
and it's problems getting a good sleeping position. And also, like if I'm in the car and I want to reach something back,
Oh, that's a big one.
it's not that it hurts so much, it's just that it hurts. You
Okay.
know? I mean, it's
Yeah.
not terrible, it
It's
isn't.
aggravating.
It's aggravating, and I don't think I'm getting proper sleep
Gotcha.
because of that.
How long have you been dealing with that?
There's some months. I have been in physical therapy before.
Okay.
And sometime back, this was a frozen shoulder. Okay, so we took care of that.
Right.
And now it seems to be getting a little bit grumpy.
Got it.
So I'm thinking maybe just the whole business here needs attention.
That's right.
Yeah.
That's right. Because I mean, what do we have in between our two shoulders? That neck, right? And then that can start grabbing all that stress from all
Right.
those compensations we're making because of that right shoulder and that
Right.
left shoulder keep you trouble, right?
Mhm.
So, same deal lifting as well with that, in addition to reaching back. Or
I mean, I
lifting's pretty
can
good.
lift, I can pick up, it's like
It's just that
you know,
stress in the front that gets you, and as
just
well as
certain
sleep.
positions. And then if I sleep on my left,
Mhm.
as I've had to do, then I'll put a pillow here so
Okay.
that my shoulders are not, bowing in.
Smart girl.
Slow down now, you're getting a little too fast. No.
She's in
That's
her space.
right,
Yeah.
that's right. And, check.
Mr. Remedy? My name's EJ, and pretty much right shoulder. Mostly throwing balls as a kid. I wasn't a big ball player, but I did a lot of adventure sports stuff.
Yeah.
You know, rock climbing, hiking, backpacking.
Pretty active.
Yeah.
Okay.
I do a lot of driving now, so,
Mm.
That's a killer on you, the driving.
yeah. On a
Well, with, on the wheel or just resting right here?
Well, I drive
You
left-handed,
drive left-handed.
so I have issues with this elbow too.
Obviously, yeah.
I'm sure it's probably similar with rotator stuff, but more with
Yeah.
tendonitis in this one.
Right, and then that's another topic we're not into. Anytime you're dealing with something going on in the shoulder, there's multiple different variations of things, right? And it can either extend up, like I mentioned earlier, or extend down into that, to the hand, to the elbow. Yeah, so it just causes a whole bunch of, it's a big mess, right?
And we know this lady.
Yes,
What-
Teresa.
What is bringing you here, Miss Teresa?
My left shoulder, sometimes I can't lift higher than,
Then by shoulder height?
yeah,
Okay.
it'll pop. If I move a certain way, I feel it popping in there.
So when it pops, does it hurt?
It hurts all the time.
Hurts all the time, okay.
All the time, like right now. It's just a dull ache in there. And of course, my shoulders are curving in as I hunch over at my desk or backward. Well, this whole side of the right side of the body got all beat up when I was about 16 in a bicycle accident. So all the joints on the right side are unhappy, but right now it's the shoulder that's the most unhappy.
You have most issues, okay. And as well, reaching back as well? Yeah, don't ask her.
Getting dressed into my undergarments is a challenge.
Yeah.
Trying to reach around.
Okay. All right. Well, thank you all for sharing. Sure, like, every, action they all have mentioned, we're gonna get into and kind of give you all some insight on what we think as therapists. First, what we do for it, and, you know, some of the different mechanisms that can potentially cause impingement, issues that could lead to tears, such as yourself, and, you know, especially necks too. As therapists, we do a pretty, I think here especially, we do a pretty decent job in screening like cervical spine, 'cause sometimes these shoulder pains not really coming into a true shoulder pathology, right? MRIs could show some imaging like wear and tear or arthritis, but the true issue could be stemming from the neck. So it's important to kind of screen that and make sure all the nuts and bolts are aligned. Right. So, well, again, we'll get into more detail with that. So,
On to me.
yeah.
Does anybody know what the rotator cuff is? Anybody? Anybody?
It's a group of four muscles.
Hey,
A plus, A plus, very good, very good, way to read,
I read the back of
way
this.
to read, okay.
That's the only one I know.
So a lot of people do come in and they think the rotator cuff is just one structure. And that's a misconception, because the rotator cuff is actually four muscles. So if I were to rip away my ribs here, and you were looking at my shoulder blade from the front, you have your muscle called the subscapularis. If you look at me from behind, you have the supraspinatus, the infraspinatus, and the teres minor. And all those muscles come together to stabilize and move the shoulder joint. The shoulder joint is a ball and socket. So you think about the hip, another being another ball and socket. So this would be traditional hip ball and socket. You can see with the hip, you got a ball, you got a pretty deep surface or articulation there. So it doesn't allow for many degrees of free movement. You know, we don't have as much movement in the hip that we do in the shoulder. It's because the shoulder, if you look at the ball to the cup here, it's more of a golf ball to a golf tee kind of situation. So it's really important that those muscles, rotator cuff muscles, and some other accessory muscles kick in to stabilize that joint, to allow you to move and allow you to move in a pain-free way. So what do we do with therapy? Okay. Like he said, we're very thorough. We're gonna look at multi-joints. There's a lot that goes on in a shoulder impingement. You have to look at the shoulder joint itself. That's, you know, integral. But you have to start at the neck. You have to make sure that a nerve isn't getting pinched in the neck and maybe causing some weakness in the shoulder, or referring pain from the neck to the shoulder, and even as low as the elbow or lower. I've seen some people complain of like tennis elbow, and it ends up being coming from the neck. So we'll rule out any kind of neck pathology. We also look at the movements of other joints. The shoulder blade, there's a normal mathematical rhythm that shoulder blade has to move in line with the arm and humerus, or the long arm itself. If that's not moving adequately, then you're gonna potentially have problems. you have to look at the collarbone. The collarbone has got to elevate for that shoulder to move up. Feel it. Put your hand on it.
So use that.
Preferably be maybe on your painful side.
Yeah.
But, you know, put your hand on it and you feel how that kind of elevates. So sometimes that gets stuck. So as therapists, we have to kind of get that mobilized and so that it can move in an appropriate manner. And then you have to consider the ribs. The ribs have to be able to expand and open up for you to elevate your arms as well. So that's where therapy kind of differs from just, hey, let me call my friend and see about getting a couple exercises, because you can do a couple exercises, but if you're not addressing those other core pieces, you're not going to get any better. So,
Yeah, that's right.
got that?
Got it.
All right. So success stories. Go ahead and tell them about one of yours.
I have this gal came through this rotator cuff shop initially when we first started having these in I think it was back in June last year. She was very unstable. So she had positive findings on her MRI with instability with rotator cuff. I believe it was a small tear. It wasn't a great tear. But what I mean by instability is every time she lifted her arm up here, it was popping greatly. So it limited her. She didn't want it to pop. She didn't want it to hurt. And Mr. Reese, the reason I asked you if it hurt when it pops, because you can also have unstable joints that pop, right? I'm sure some of y'all may have had that on your non-painful side, where it just pops and it's weird, why is it popping so much? And then you also have the issues where it pops and it hurts. So the popping sensation, that's a whole other issue itself, but it doesn't necessarily mean that it's problematic unless it's causing your symptoms. Okay, so that's what I want to say with popping. So anyway, back to my lady. She was very, very painful arc, is what we would call it, as we lift the arm. She just stuck right here. So it was about 2 or 3 solid months of just trying to get that joint back stabilized, right? Passively is one of the terms we like to use, try and get the arm to move by itself without her having to do it. And that's one of the ways we kind of progress, getting those muscles awake again. Like in her case, her rotator cuff was just shot because of that tear, because of the traumatic episode she had, and she was a yoga instructor as well. So, you know, apparently she was not teaching yoga. So all in all, we finally got over multiple humps and a lot of tears later. It was really, I believe it was 4 or 5 months of therapy, and she finally got back to teaching yoga. She was in tears leaving out here. We were all like very emotional. It was awesome. It was awesome. But we got her back, and I mean, I will never forget that day. That was amazing. So you got a story for you.
Okay, hopefully, yeah.
Well, you follow that, right?
Hopefully, I don't know if I follow that. It's big shoes to fill. No, I mean, I recently just had a gentleman come in mid-November. We evaluated him. Couldn't get his arm above shoulder level. Was definitely having issues reaching into his back seat, like y'all were talking about. Mechanism of injury, just throwing his kid up in the air in the pool. Wanted to get back to being able to do that. He was a desk worker, always everything kind of to the front, everything forward head, rounded shoulders, everything just tight in the front. So we assessed him. He had gone to the doctor. He had had x-rays. The x-rays returned normal. He had the injections. It didn't touch it. So they come to therapy. We, find, of course, everything in the front. The pecs are really tight. So we start doing a lot of soft tissue work with that gentleman. Collarbone elevated, mobilized that a good bit. Shoulder blade was not moving. Everything in the back was just on lockdown. So we really worked on mobilizing that shoulder blade. And from mid-November to New Year's, he was back to doing everything he wanted to do. He was happy camper. So that's my most recent success story. So we're happy with that about Brandon. And we didn't cry, we're not sensitive like this guy. But at the end of the day, we were happy and taking pictures.
I'm getting emotional just thinking about it.
He's the softie, I'm not.
Well, he's
Big old teddy bear.
He's the teddy bear, I'm the mean one. Alright. So y'all talked about MRIs. Alright, a couple of you have already had the MRIs, they've identified tears. MRIs are great. If y'all bring in, results, we'll look at it.
For sure.
And a lot of times in my case, I kind of dismiss it. The MRIs, there's a running joke, are as good as long as you're laying on the table. I've heard that one. They did a study some years ago, and they grabbed a sample of 100 people. And these people, none of these people had a symptom in the world, not a pain in the world, happy-go-lucky people. And they did the x-rays, did the MRIs. They were looking for arthritis, impingement, rotator cuff tears, What else were they looking at? They were,
Yeah, OA.
osteoarthritic changes, just to see what may be going on in the shoulder. Well, it turns out, let me ask you, of the 50-year-olds, what percentage do you think that they found some kind of abnormality in the MRI?
90%.
80%. So you started getting into the 60-year-olds, where do you think they fell in?
Yeah.
90%. You started hitting an 80-year-old, and guess how far we got? 99%. So, I mean, they can show stuff that can be helpful, but at the end of the day, they're not always the most reliable thing. The other thing that you can deal with an MRI, or you deal with, is that you're dealing with a static image. They're not looking at you through the movements. So they may not be seeing down here, everything's fine, but they're not seeing that once you hit here, that tendon's getting pinched up under there. You just got this static version of what they think is going on, but who works with their arm in a dependent position all the time, or laid on a table all the time? That's just not happening. So, what are some solutions? You said, who's had the injections? Anybody?
I have.
Did you have any success with that?
Yeah, it felt a little better, you know, but it's
They're
still,
great.
it comes back, the pain comes back.
Exactly, so
It's a Band-Aid.
you worked to alter the pain, and that's what they'll do. They'll dose it with the injections, they'll dose it with topical medical, medicines, they'll dose it with, anti-inflammatory medications. And ultimately, that's fine. There are cases where we get patients in here that are so flared up that we have to send them back to the doctor because they're just so intensely in pain that we can't accomplish anything. So it's not like this, taboo kind of thing to go get the injection. But, at the end of the day, you're really just masking the symptoms and you're not getting to the underlying root of the problem. So the likelihood that those symptoms are going to return is pretty high. So that, and I've done research studies when I was in PT school that actually showed that too many of those injections start to degrade the joint, and then that potentiates more injury anyway. So.
Yeah, we talk about long-term use. Of
Yeah,
steroids.
I mean, generally they won't do more than 2 or 3.
A year.
Yeah.
Because of that fact.
So.
And you already have a degraded tissue status to begin with, right? So, like you said, it's more of a inflammation control method. But what are you going to do in that time where it feels pretty good, right? You got to rehab it. You got to get it moving. You got to introduce it to new stimulus. That's how these tissues. That's how your tendons, your ligaments, the bones that are attached to these ligaments and tendons. That's how they get stronger, right? Through stress and through controlled stimulus. It's not like, okay, go to the gym, you'll be all right, you figure it out. It's more like, well, with all these mechanisms moving, the neck, the collarbone, the shoulder blade, the rib cage, there's a lot of different parts in play. And if you go to the gym and kind of do some generic stuff, you could be doing great for yourself, you could be doing more harm. So that's kind of where we step in as some of the specialists and kind of realize, like, okay, well, this looks great, but this looks a little stuck. So let's kind of focus a little bit on this. And we'll kind of get into more of the details of the hands-on portion. There's a big aspect of this where we as therapists, we can see some things. Like in a minute, we'll do a little exercise with y'all, and we can see some things. We can deduct some things from our experience, from what we know how things should move. But ultimately, we need our hands on you. We need to kind of see and feel how it goes. So I mentioned earlier about the passive movement with my lady. Like she couldn't do very much here, so I had to get in there and do it for her and kind of introduce that stimulus again to the joints. Okay.
Call us the fine tuners. We're the fine tuners.
That's right. Posture police and fine tuners. Physical torturers as well. So, yeah. All right, so here's a little exercise I'm gonna show you. I'm gonna pick a lucky volunteer. But first, I wanna kind of see how y'all go. So,
Set your pads down.
yeah. Go ahead and throw those down. Get this chair. You wanna break it through? Stop.
What's that?
Okay. Yeah. All right, so everyone, non-painful side. Go ahead and look straight up for me. All right, so pretty good. All right, come on back down. That's got a pretty good lift there. How about the painful side? All right. Kevin, come on.
That was gonna be my pick. That was gonna be my
You
pick.
had that little face jerk.
Oh, it hurts.
Slow.
Yeah.
Man. All right, so again, we mentioned we mentioned earlier that, you know, there's a lot of moving parts, and the one thing I wanna try with Kevin here is something called a first rib node. And ultimately, if you kind of dig right behind that clavicle, kind of in the tender spot, you can imagine there's a little bitty bone sticking out from your spine that's kind of hovering there. And the responsibility is this.
Yeah, it's,
Yeah.
may I touch on you?
Absolutely.
You got this big muscle right here, it's gonna come just before that and in between that collarbone, you feel this right up in here?
So right in between that upper trap, that big muscle belly, and that bone, you're gonna have a little gap, and I want you to kind of just give it a little gentle pressure, and it's gonna be a little sensitive, okay?
Yeah, it's not a.
If you feel bone, go back a little bit, if you feel muscle mass, go forward a little bit, but that's ultimately your
You
first
feeling
rib,
it?
okay? You got it, ma'am? Got it? So that's, you know, that's extended from the lower part of your neck, and as you can imagine, it's kind of protruding from your neck into the shoulder girdle. So if we have some implications that your neck is a little stiff, we can address this one particular aspect and hopefully get this shoulder moving a little bit. So, let's go ahead and lift that arm up for me one more time, straight up. All right, give me a pain number, 0 to 10. The almighty.
I give you about an 8
Right now? Okay,
Yeah.
go ahead back down. Is that localized here, in front, back,
It's like inside.
inside?
Yeah,
Okay,
so-
deep inside. Gap here. All right, so set nice and tall for me. So all I'm gonna have you do is continue to look straight and just bring your right ear to my knuckle. No, I'm sorry.
Tilt your
So it's from the tip
Oh,
of your
okay,
head.
that's about as far as it goes right
That's okay,
there.
that's okay. So I'm gonna
Next
do
time,
a
too.
set of 10, so go ahead. Good, and then relax. And again. Good.
Doesn't look like happiness to be there.
No, that's about a 10.
So here's a question for you, does it settle down when I stop pushing on you?
What's
Does
that?
it settle down? Does that pressure that I?
Yeah, yeah.
Okay, okay, go ahead again. Very good, again. Good. And all I'm really doing is giving some gentle, he would disagree with me, but, some gentle pressure to that one little aspect of this neck. In hopes of.
Which is tight.
Which is tight, oh yeah, it's tight, go ahead, keep going. So the reason I'm having the side bend is to kind of give more motion to that part that I'm trying to mobilize on its own. And in theory, the reason I picked this one is to hopefully let loose of that trap and let go of that tightness in his shoulder joint. Okay, let's do two more good ones. Good. And, all right, so, go ahead and lift that one more time. That's up.
Yeah, it's better. That is better, actually, it's better.
You didn't miss that time.
You didn't miss that time, you came up a little quicker.
I mean, it's better.
Okay, I'll tell you after, okay?
It's a miracle.
That's what we call the 5-minute miracle.
5-minute
How did you
miracle.
go?
He's on it, he's a market, he's checking buttons.
We don't even need the market. Let's get this guy. Having you hard.
Yeah, all right.
So, yeah, ultimately, that's just a small example of us getting our hands on you, right? That's kind of how we practice, that's how a therapist should practice, in my opinion, right? Every therapist is different, just like every doctor is different. You gotta find one that suits you, and that just to give you some insight into how our principles align with getting you back to feeling better.
Well, can you explain what you
Yes.
did? Because I wasn't really paying attention.
No, of course, of course.
Because I was hurting, yeah.
Can you explain what that actually did?
Of course.
For the,
So.
how this affects the road.
Oh, yeah, that should have a spine. Yeah, there's a spine.
I will look.
Yep.
Do y'all have any questions so far about anything while you're sitting in with me? What you got?
I have a question. Sometimes when I yawn, like when I'm driving, because so many muscles are involved, I'm driving while I yawn, and I get this tremendous cramp that comes up either here or here. It's like a burning pain. So then I have to keep moving the neck until it just kind of settles out. I wonder if that had to be related to all of this other
It
stuff.
could definitely be tied into that, postural issues, myself included. Believe me, I'm not the poster child for good posture. It's just quite the opposite. But, your posture affects your jaw alignment. You see a lot of people that have TMJ, and, you're talking about yawning and it reproducing pain. When you have that forward head, rounded shoulders postured, it actually drops your palate. It'll change how the mechanics of the jaw opens, and all of that can affect the muscles in the neck, and then secondarily into the shoulder as well. So yeah, I mean, it could be a simple fix. We, you know, I've always told, you know, my therapist that we should market to the dentist before they start fitting y'all with the night splints and things like that for people that had TMJ, to address the postural issues, to get things better aligned before they start prescribing these $500 implants and stuff. Not that, you know, the therapy would be cheaper and it would help more things versus just that. So yeah, it may be related for sure. Thank you.
So that's the perfect model right here. So this is your first rib, kind of just sitting along right your lower cervical spine. So here's where your head would sit. And this bone, you see all these muscles that attach to the side of the neck. That's pretty much what its job is in respiration. Whenever you breathe in and out, it kind of helps lift the rib cage up to allow those lungs to expand. So ultimately, what I did with Mr. Kevin over there is I had him side bend, so naturally that would drop that first rib, and I also gave a little pressure to it. So similar to all of our talking points prior to, you know, this neck has a whole bunch of attachments from all these vertebrae to this scapula right here. Okay, now I'm gonna have a very good picture right here, but ultimately we have the upper trap that pretty much, it's the entire aspect of my hand. It's very superficial. So say you just, forgive me for being so, I don't know what to say, but say you peel the skin back and superficially, boom, upper trap, that's what you would see, okay? And it is pretty much the cover to both your neck and your shoulder blade. Okay, so that's just one aspect of it. So ultimately, you're addressing some of the soft tissue that could be kind of guarding, right? Good posture that also affects the elevation of the shoulder blades, which, you know, drives this humerus right up into acromion. And what do you do when you're jammed up and you lift? It just gets pinched even more. Okay, so ultimately everything's connected, and whether you're talking about your neck or your mid back, you know, it extends from the spine. So I mean, spine that's groundwork for any extremity issue. Did I answer your question? Okay, what's next?
Tell them about you.
Oh, about me. Oh, I almost said one about me.
Of course, tell
But,
them about you.
So again, I'm Don. I've been here for about almost a year. I've been a therapist for about 4.5 years. Graduated from Southeastern and went to LSU Shreveport for my postdoc from PPT. So why am I up here talking about shoulders in front of you guys? What qualifies me, I guess. So I'm more of I love spines and shoulders. It's just, you can cause so much change with the amount of, with the degree of movement we all naturally have. Like the reaching back. Like I can, well, like right now, based on my experience, like boom, boom, let's try this 1, 2, 3. And likely we're gonna hit the mark on one of them. Maybe not like 80%, 100%, but we're gonna get like maybe 10, 20. And I mean, that's good enough just to get a rolling start, right? So just the ability to be able to make those small changes to eventually lead you down a path of just stop being, just live, enjoy your life. Stop being worried about this, because this is nagging, it's aggravating, but like you don't have to be like that, you know? So now, we can get into the next graph, but like things have changed over the last 20 years, and Dee will kind of get into that, but like I've seen some great things here in my past experiences as a therapist. So yeah, I just really enjoy it, and it's so awesome. So yeah, that's kind of about me. Dee?
I'm Dee. I'm the newest to the clinic. I've been here for a little under, or right at 2 months now. I've been practicing for almost 15 years. 14 years of that in ortho. I worked for 7 years directly with a shoulder and knee specialist. So this is my bread and butter. This is what I love to do. I like spines okay, but definitely the shoulders and the knees are my home. Like he said, I love what I do. I was victim to a therapist for 8 months thanks to a drunk driver, so I have a big passion for this. And like he said, it's just that hands-on approach and those little small things that we can do, those nuances that therapy has to offer that can get your life so much better, and, you know, just altering people's lives like that just makes coming to work every day a pleasure. So that's what it's all about, just getting your lives back. I always joke, and I know this is probably inappropriate, but it's, you know, you talk about people, and it's all about the little things. And it's a huge deal after somebody has a rotator cuff tear to go, I like my own butt today. It'd be high-fiving, you know, it's a good day. It's little things you take for granted that we can get your life back, and that's what makes this job so great. So why he leads into that, he's talking about the grafts, funny he should mention. So this is therapy 20 years ago. Therapy 20 years ago, I think, was a lot more hands-off. It was a lot more glorified athletic trainer. So what you saw was when they got their intervention, you had probably about 25% of them that actually had great outcomes. Then you had 50%, they got better, didn't last. And then you had another 25% that was just no better, no worse. So you got relatively a lot of unhappy patients. But you look at therapy now, hands-on, you got 90% of these patients that are getting better. You got 10% that need referral back to the doctor. Maybe you do need the surgery. Maybe you need the surgery. But we got a 90% chance of doing something, some sort of good in your life. And the difference is the hands-on. The hands-on, absolutely looking at the neck, looking at how everything moves together. It's key. And let me tell you folks, not all therapy is the same. You can come to this clinic and you're gonna get somebody that's hands-on like that, and you're gonna go to another clinic where you've got your glorified athletic trainers. The key is hands-on. If they're not hands-on with you wherever they go, you're probably in the wrong place. Did I get it all?
Alright, so, let's refer back to the worksheet that y'all have. We'll go with number 3. I believe we addressed number 1 and 2 already. I want y'all to have a little bit of a resource from tonight. Does anybody have questions about number 1 primarily? No, everybody got that? Okay. So number 3, back to normal, first steps. So if we as a clinician, or you as an individual who's looking to get better, if you can reproduce that pain, something that's emotion or resistance or carrying something, then you are able to reduce it. Okay, so if it's reproducible, then it's reducible. If you're proactive, you can reduce it. You can take care of it. Okay? Where we are.
You got that pain at rest though? It has no specific mechanism of movement that makes it work, things like that. This is also where therapy becomes important too, because we can differentiate whether it's something that is a mechanical problem that we can solve or you know, resolve, or whether or not you need to go back to the doctor that maybe something serious is going on. Maybe there's an underlying tumor or something that, you know, we don't know about. But, you know, pain at rest generally isn't a good indicator. So it's a good place to get here to be able to diagnose that out as well.
So even if you didn't come from a doctor and you don't know where to turn, we also are a really good resource to kind of point you in the right direction if necessary, right? Okay, letter B. In the past 30 days, the worst pain I've had was, go ahead and write that number down. I like for you to have this fresh in your minds, because whenever we address this, these are things we're going to ask. Okay.
Tell him 10 when he just pushed on you.
Oh, so
Rub it
you
in.
want a number?
Rub it in.
number.
Oh yeah, rub it in.
2 digits. That's the highest. That's it.
0 to 10. 10's being Don's working on your shoulder.
I had it.
And letter C, I have pain when, and we have a couple of options here. Go ahead and circle each one. That is all of those. That's one big general bubble. Let's see, where do y'all have this? Okay. So this is the part where I mentioned sleeping. So I'm going to kind of go over small aspects of that. So, who here are stomach sleepers?
Sorry?
Stomach sleepers.
Welcome to our clinic. Welcome. Our first sign up right there.
So,
Can I sleep on your stomach? Go figure.
so side sleepers, back sleepers? Side. Okay. So, you have a majority side sleeper. So, say left arm's okay. I can tolerate laying on it, right? What I have you do, prop a little pillow in there, give it a little hug, and off to sleep you go.
And that's bad shoulder.
It's my bad shoulder.
Yes.
Yes, I'm
Yeah,
sorry.
I've
Laying on
always
my
done
side.
that.
Okay, so let's say I don't want to do this for whatever reason, right? You know, whenever you get to this position, like I enjoy it, it makes me feel better when I lay on this shoulder, right? It's an important point to think about. Whenever you lay on a joint and you compress it, you're kind of slowing the blood supply, you're compressing those nerves that are surrounding the joint, right? So if you must, I'd like for you to kind of get a couple pillows behind you, and kind of lay off of that arm a little bit, okay? Now, these are all recommendations, right? But on eval, me personally, I'm sure, we address sleeping, but it's a work in progress. Like, you sleep 6, 8, 10 hours a night, you're not moving, you're tossing and turning, you don't, you're unconscious, you're sleeping, you don't know what position your arm is in, right? So if we can address more when you're awake, during the waking hours, then that should carry over into the sleeping postures, okay? So, bad shoulder, side sleeper, right here. If you need to, put a pillow behind you, kind of lay back, that'll also give you a little bit of a support structure right here, okay? Yes.
I now sleep with 5 pillows.
Ooh.
I'm trying,
We got 1, 2, 3, 4,
That-
5.
pretty much.
And a pillow fort.
Yeah.
Okay, do you have issues with sleeping with your pillow fort?
Well, because of the discomfort, trying to find
Trying to find it.
trying to find a place. That works a lot of times, and sometimes with the pillow, then it's like this. And then sometimes I'll lay back and just on my side and just put it under the other pillow. It's never one thing all night.
So that, I would address that with more of a dynamic exercise. So when you're during the day, posture is going to be a big role. We're going to have a little bit of a demonstration with that as well. But there are a couple key things you can do to address your posture, because ultimately throughout the day, your waking hours, you're jamming, you're doing your thing, you kind of getting tired, everything's here, you're already compressing, you go to sleep, then boom, what happens? Compress more, and this is repeating the cycle, right?
Yeah.
So it's important to, whenever you're conscious, whenever you're awake, you're more aware of your positioning. That way, you know, you're more aware of it, your body's just ready to rest, and sleep's important, right? That's when our healing time happens. So, sleeping's a rough go. It's hard.
How many of y'all are recliners?
Ooh,
Anybody made the recliners yet?
Fantastic.
Not uncommon to hear after a rotator cuff repair.
Yeah.
A goal is always for us to get you back into your beds, and some people do just before, post, or pre-operatively find themselves so unable to get into a comfortable position to sleep at night that they end up in their recliners. And for that reason, they're on their back, their arms supported, it feels better.
For prone sleeping, my guy back there.
Oh yeah, welcome, let's sign up on the way out.
That's rough, yeah.
I can sleep any kind of way though.
Well, there you go.
But usually I fall asleep on the belly first and then fall asleep.
You're gonna end up somewhere else. Okay.
All right, let's, did about all the sleeping thing? Yeah, okay, you gonna go next?
Where are we at?
Number 4.
Number 4, what's the biggest mistake that shoulder sufferers make? You ignore it. You just keep pushing through, you keep doing whatever it is that keeps doing it, it'll go away, I can deal with it. Teresa.
3 years later.
And, you know, it gets better, it gets worse, oh, it'll go away this time, but there's gonna be a point in time when you come see us, and it ain't getting right no more. So it's really important that you get more proactive. I always tell people, you know, it is so much better to get in here sooner than later. You know, once, you know, you want to, so much better to get in here sooner than later than, you know, before you just really start changing how you move, how you sit, and changing all the postural aspects that go with it. It's just a cascade of failure. That's what we're, you know, going to happen to you. So better to nip it and not ignore it.
And we really appreciate y'all showing up today, because that tells us.
Big
like,
step.
we're ready.
Big step.
I mean, big step.
So what's the second thing you can do to address it? You can alter it, right? You can go get those shots, you can go get that medication, you can go get that topical cream. But we talked about the problem with that. The problem with that is just, you're not gonna fix it. You're just gonna change the symptoms for a minute. Maybe it works for a time, maybe it gives you a couple years relief. I've seen that happen. But you'll be back. You'll be back. So, what's the third thing you can do about it? learning, hopefully you'll come see us, and we can show you the way to how to handle it, so that you don't end up in another seminar at some other clinic. Alright,
There's another point I want to make. During my training, I was told by my superiors, like, everyone deserves an assessment, at least an assessment. You know, we learn a lot by looking, but like we mentioned earlier, we keep alluding to, it's when we get our hands on you and we really feel what the problem is, right? Tenderness is something to be spoken of, should that go like that? Like, what's going on here? And we'll be able to answer those questions.
I always love when people go, it hurts, is that normal? I'm like, is pain ever normal? Yeah.
Is that your normal?
Is that popping normal? No, I mean, it really shouldn't be popping, but pain
Yeah.
most certainly, not normal, yeah. Alright,
Yeah.
so I mean, that's what he talked about, what's the most successful non-invasive treatment look like?
Physical.
It looks like us, it looks like us, it's getting in here, restoring muscle balances, restoring joint mobilities, educating you, it's the full package, just getting you well. And hands-on, cannot emphasize enough, hands-on.
Do we skip number 6?
Maybe.
No.
Yes,
Yeah.
top 3 causes of shoulder pain. Problems in the neck. We don't have our neck model, huh?
No.
We don't have our neck model. Ooh, can you find a neck
I know
model?
that, I think it's 6. Taking the good ones. What's that?
What's that?
He knows where it is.
Yeah, he's the one I'm always like, now I know my go-to man when I'm looking for it. You know, so at the end of the day, you've got to factor in the neck. Now, this is a lumbar spine, so obviously this is a little more grandiose in scale, but the principles are the same. You have the disc in between the 2 bones. You have the nerve roots that come out in between the bones, and those nerve roots, depending on where they are in the spine, are what supply the arms, the legs, respectively. So you can see that if that disc becomes desiccated, and that, you know, is a normal wear and tear aging process that starts very early, much earlier than you think, but you start getting that pinching on the nerve, that can start contributing to the weaknesses in the musculature, sometimes the referred pain. So again, it's really where it's important to start differentiating, do I have a shoulder problem, a neck problem, a shoulder and neck problem? Because you may be coming in here for more than you think.
Or less than you think.
Or less than you think.
You never know.
Second cause of pain, impingement. Where did my shoulder go?
Run away from me.
All right, impingement. What is impingement? You have your 4 muscles like we talked about. You have a very narrow space right here between what we call, this is the spine of the scapula, and at the end it's called the acromion. And the acromion up here meets the collarbone. And where that meets, it forms an arch. And you can see that at least 2 of the tendons kind of pass through that arch. Now, I tell my folks, you can see, this is a model, and you can already see how narrow that arch is and how much clearance it really doesn't provide. You start throwing bad posture, you start throwing a bone spur, degenerative changes in there, and you got even less space. So impingement basically is, my joint's not sitting right, I go to move, and then that tendon gets pinched up into that area. So that's your impingement. All right, and the last and the biggest thing you're gonna hear us nag the tar out of you about, posture. You want me to demonstrate this one?
I'll do it with you.
Yeah, all right.
I love it.
I have terrible posture, so I'm a prime example of what not to do. So I want you to put your papers down for just a second. I want y'all to do this with me. I want you to sit up nice and tall and try and raise your arms up. It's not so bad, right? A little bad, I'm sorry, because you hurt. You hurt. Now slump and try and raise your arms. Yeah, okay? You see the difference? So this is why we nag the tar out of you about posture. This is why we address between shoulder blades so much. We address middle trap, lower trap, rhomboids, things like that, trying to get you out of what we call accessory motions, this upper trap compensation that you'll see when people go to move. And that's why a lot of people come in with neck issues when they have shoulder issues, because they find themselves, you know, really clawing up with that muscle there.
That neck, not much room for it to move. So number 7, I think we addressed the hands-on PT. The letter B would be strengthening exercise. I have it right. Strengthening exercise to retrain muscle memory. And, I spoke earlier about gym-based exercises and gym-based movement. Sure, you have a chance for just higher activity to get things rolling, you feeling better, right? But you always run that chance of those cable flies or those presses, you know, it's a little too much that you needed to start ramping things up again, right? And what I mean by that is, you're doing a lot of forward chest work, right? A lot of,
We see a lot of bench pressers, incline pressers, individually, when they come in, they're like, I was exercising, what were you doing? Oh, I was bench pressing.
and not even that, but it's like dumbbells, like, what, you think, okay, I'm gonna raise my arms, I'm gonna come in front of me. So for whatever reason, us as humans, we just think like, I gotta strengthen my shoulders, but we just forget about the backside. So we need to retrain all this, the lower trap, the upper trap, getting it shut off, getting the rotator cuff stabilized so that humeral head won't start hiking up, it'll stay down. So we'll stop having all those impingement signs. Okay.
You gotta work more than the mirror muscles. I call it the mirror muscles. We always wanna work with, you know, we're gonna be proud of. I mean, you know, turn around too often, you know, so we work the things that are bulking and gonna show up the most to your undoing.
And letter C, pain and inflammation relieving modalities. So that's kind of where the heat and ice and the electrical stim kind of fit in. We have a class 4 laser machine here, pretty powerful stuff. It's just another tool in the toolbox. Insurance doesn't cover it, but it's a pretty powerful tool that addresses, you know, you put ice and heat on something to kind of calm things down and kind of relax it. This laser addresses all that pain and inflammation with light therapy. So it's a very specific amount of energy, just driving right into that shoulder, right into that trap, right into the neck, whatever the problem location is. So that's just another option, okay? But is it gonna make or break it? No, it's just gonna be able to, can help push you forward to get to your goals a little faster. Okay.
What does that do, just controls inflammation?
So,
or-
photobiomodulation is the technical term for it. But yes, it downgrades that pain cycle that everyone tends to kind of get stuck in. Whenever you lift one too many times, it's like, oh, okay, I did something. Okay, I gotta give it a day or two or 6 hours, an hour to settle down, right? The purpose of this laser is to speed that time up. So you're not waiting 2-3 days. It's better immediately. It's one of those, you know, there's no miracles in therapy, but this is pretty close to it, right? So you
We
get
still
pretty,
need to do the therapy and strengthening the muscle.
Yeah, that would be an alternate,
That's just-
that would be an alternate situation.
yes,
Okay.
yes.
Then
So-
hook me up. If I don't do anything else.
Yeah, that's something else we can address if you on the side of it. Okay. So, to review, anybody have any questions about anything? Yes, please.
Somebody that I know
Yes.
goes to Hotspot for like the far infrared. Am I saying that right, for infrared?
Mhm.
Yeah, is that similar to what you
It
described?
uses infrared light, yes.
Yeah.
It's a certain wavelength, that we got glasses on, you don't look at it, and we turn the lights off, close the doors, keep everybody away, and, yes, infrared light, damaging to the eyes. But I mean, I have had it on me, and have you had it on you?
I have had it on.
Yeah, it is spectacular. But there are some details about that we can discuss. Okay.
I do have a question.
Yes, please.
All that stuff you talked about that, you know, we can do.
Yes.
Will it also help if you have a torn tendon?
It depends on the degree of the tear.
Yes.
Yeah, because I do have that.
If you're dealing with a partial rotator cuff tear, that is a potentially fixable situation.
It is.
Now, if you have what's called a full thickness rotator cuff tear,
A foot what?
full thickness,
Mhm.
meaning that the bone, the tendon has completely come off of the bone,
So
like this bicep has completely come off the labrum.
Like the back, yeah.
There's no chance that therapy is gonna reapproximate that muscle to its origin or attachment.
You call it, tell me one more time.
Full thickness tear.
Tear, okay.
So based on how everyone's lifting that arm,
I don't
No
see,
one's
I don't
got a
see a
full
tear,
thickness.
I don't see a full thickness.
this would be what we're.
It would
doing
be
here.
a flop.
But a small tear, doing your physical therapy and everything would help fix it.
That can fix it.
Mhm.
I mean, I could get the mobility
The
back.
tear's not going away, it's just that you're strengthening your muscles.
Around it, there are a lot of moving parts, that one rotator cuff small tear is not gonna dictate you being able to lift. There are other, compensations that can be arranged through rehab, but, you know, we say compensations as therapists, typically in a negative manner, because typically the upper tract conversation is one of the most common one.
Mhm.
But, you know, to get you to that point, everything else gotta play along. It's gotta almost support each other, right? It's a
Mhm.
support system.
You know, I do a lot of yoga, I do yoga every day, and so I can still do my exercise.
Yeah.
You know, up and down, lots of push-up stuff, and, but, you know, I cannot go like this, you
Right.
know, and do all of that stuff on this side. But, so I don't know, whether that is good for it or not, you know, or, but I figure if it doesn't hurt me, it should be okay.
Right, and you kind of, you know, that's kind of where we step in with some guidance, and
Right.
with experience and with treatment measures. You could be fine, right? But it could just take that one little bit too much to hit a breaking point. Now all of a sudden you can't put weight on it, right?
Right.
So, you know, there's the idea, not idea, there's theory, I suppose, stability over mobility first, right? That shoulder blade has to be stable on that rib cage, so this arm can do what it needs to do,
Yeah.
right? If that thing's unstable and it's kind of going janky-like and it's not really working, then that arm's just not gonna have anything to grab onto,
Yeah.
right? So everything starts right at the base. Again, that's part of our assessment measure.
Yeah, and I am in pain, so, but.
And we also have to consider that as
Yeah,
well, right?
that is a problem.
You can have full motion, right? But you can still have that pain that
Yeah.
you don't have on this side that's brand new, that just kind of sporadically popped up for whatever reason. And yeah, there's definitely things we can address.
But if it's hurting while you're doing it, probably not the best thing to be doing it.
Yeah.
Probably
So that-
If it's hurting while you're
No,
doing
no,
it.
I know that, yeah, that I
Probably
know,
not
I'm
the
very
best.
careful, yeah, yeah.
Yeah, in yoga, there's so many modifications that
Right,
you should be
right.
on.
Any other questions?
Teresa,
No?
come on,
Okay.
ask questions.
I thought that,
No, I was just stretching.
okay. Okay. Well, I really appreciate everyone coming out tonight. We got a pretty packed schedule next week, but we have some spots because we knew you were coming. So we have Candace and Sherry. Candace, Sherry? you want
So
to-
what they'll do is,
Ready?
you know,
Yes.
set up some free screens where we'll do like a quick assessment of the shoulder. We'd be able to tell you what we think is going on, whether we think you're a good candidate for therapy or do we need to refer out. And then based on that, you know, if we determine you're a good candidate, then we get you in for the full-on major eval, and then we'll go for treatments there. And that'll include the hands-on, the modalities, the exercises that'll guide you through your wellness.
Any other questions? All right. Well, thank you so much. We're all
Thank
good.
you.
Okay.
There were a couple of forms on my clipboard, if you could fill those out, that'll help us when we, get you up front to schedule those appointments.
And there's also some feedback papers on that, so if you wouldn't mind filling those out, that y'all just make this so much better.
I wish Dee hadn't said that, or, you know, I wish he'd have said it.
I don't like the tall goofy guy, he was bothering me. And we'll be here for questions. Bye.
And hopefully we'll see you here, especially Teresa. Not just on paperwork.
Now, insurance does cover it, right?
Yeah.
Yeah,
Yes,
yeah.
ma'am.
That's what I'm.
Yeah, why don't you follow me
Yeah.
and